Hi, everyone. For those of you that are here, we're going to wait a few minutes for some people to join. But if you can use that Kahoot link, go ahead. I'm also realizing that there's only four of you here. So still do the Kahoot. We'll talk through a lot. Olivia and I are together right now to run through some stuff. Oh, more people are joining. So maybe we'll wait like a couple more minutes just to give people a chance to log on.
Thank you for the cahoots, y'all.
Absolutely. We have to give some credit to Calvin and Ish. They're the ones that made a majority of these slides, and then Olivia and I are going to run through it. Um, on the note of PowerPoint slides and Cahoots, Olivia and I just finished editing the TA review for your guys' exam on Monday. I'm going to try to send it out tonight, but it needs to be approved by admin, so you guys will likely get an email for it tomorrow morning.
I have a quick question. Will we have access to the cahoots after, or is it like a private type of event?
You will have access afterwards. I'll give you guys the link so that you can look at the Cahoots. But there's also slides associated with this. So you
Hmm.
guys will have access to the Kahoot and the slides.
Okay, perfect. Sorry if you already gave these instructions. I just wanted to ask. Sorry
Oh,
for
no,
being
no,
late.
no, I did not get this out yet. All right. So I don't know. I mean, do you want to? Olivia's sitting right next to me. So if you hear me saying something, I may not be sending to you guys. Do you want to just get started with? There's only a few people here. Okay.
Hi guys. It's going to be a fun session and hopefully great prep for your exam on Monday as well as the practical. So definitely pay attention, take notes, and you'll be able to should be able to revisit the slides afterwards. Okay, so the answer here is medial circumflex artery. Remember, I talked about this in office hours, I think last week or 2 weeks ago. And so when you have a femoral head or neck fracture, it can lead to necrosis. Partially, this is definitely seen in elderly people because remember, you lose that blood supply, which is going towards that ligament. So um, you can get necrosis of the medial circumflex artery as it is the main blood supply for this. All right, good job. So remember, when we think about the leg, it really nicely splits up into compartments. So our anterior compartment is innervated by the femoral nerve, and this includes muscles wise, vastus lateralis, intermedius, medialis, rectus femoris. Remember, those make up your quadriceps. You also have the sartorius muscle, pectineus also is involved there. Remember your posterior compartment, that's going to be more of your hamstrings, as well as your biceps femoris short head, because that is not a hamstring. Your medial compartment is going to be your adductor muscles. Also, pectineus gets thrown in there too. It's dual, and that's going to be your obturator nerve. And then your lateral compartment, you don't really have one of the thigh, but you can kind of think of like TFL kind of being more lateral, but more you have a lateral compartment of your leg, which is the urofibularis longus and brevis. Right, next question. All right, great job. This means you all listened to me because I just gave this answer away. So remember your medial compartment, it's going to be that obturator nerve. So think about in lab, you could typically see your obturator nerve in between your adductor longus and brevis. So that's a great landmark. You'll also find your obturator artery there as well. So you'll be able to differentiate nerve from artery, but that is your medial compartment. All right, next question. All right, great job. So remember our femoral triangle, our superior border is going to be that inguinal ligament. Our lateral border is going to be sartorius. And then our medial border is going to be adductor longus muscle. So gracilis is not part of the femoral triangle. And then when we think about what we find in the femoral triangle, we're going to have navel, and that goes from lateral to medial. So be the femoral nerve, femoral artery, femoral vein, and then lymphatics. And then remember that your great saphenous vein will drain into that femoral vein. So if you see a vein in lab that's running on the medial leg and going up into that femoral vein, that's your great saphenous vein.
And then the last point, the floor of the femoral triangle, the medial floor is the pectineus, and the lateral floor is the iliopsoas.
Quick question for the pectineus and the iliopsoas. How would that come up in a question on the exam?
So they could talk about like what's the floor of the femoral triangle. They could also talk about like proximal and distal attachments. So remember like our iliopsoas, that comes from the ASIS. Or no, well your iliopsoas comes from like T12 to L5. And that's going to insert on your lesser trochanter. So they could talk about attachments, and then you would have to say, oh, like that's iliopsoas.
Thank you.
So for those of you that weren't able to answer, that's my bad. I started it a little early, so sorry about that.
Go ahead.
Okay, so for this triangle and for the adductor canal, a hiatus canal, do they have similar borders? Like I remember seeing the sartorius was like the roof and that information, or is that different when it comes to the borders and everything?
I would say it's a little different because when you're talking about your adductor hiatus that the femoral artery traverses through, that's really just bounded by your tendon of the adductor magnus. So it's really like a hole like in the muscle that it goes through. So it's kind of different versus your femoral triangle is actually like sartorius laterally, medially, adductor longus, and it's just that small area that kind of sits on the thigh, beginning right at that inguinal ligament.
Mhm.
So which is not a branch of the femoral artery. So remember our femoral artery comes from our external iliac. So it becomes that after it goes under that inguinal ligament. So once it does that, it becomes the femoral artery. So the external iliac is not a branch of the femoral artery. It's the reverse of that. But the femoral artery does give off our profunda femoris. That's pretty early on. And it does give off, become into the popliteal artery as well. Okay, so for this question, so we're talking about which nerve are you testing when flexing the knee and doing the straight leg raise test. So it seems like you guys went a little bit more with femoral nerve, and I think you guys just jumped a little too early. So remember when you're doing your straight leg raise test, you're really testing like two things for that. You're testing whether or not to see if it's a like herniated disc or like a radiculopathy, or you're testing to see if it's a hamstring nerve injury when you do this. So remember with our hamstrings that technically they're innervated by the tibial nerve, and then the short head is by the common fibular, but those two nerves together make up the sciatic nerve. And so when you're doing this test, you're going to be testing the sciatic nerve. So it's not going to be the femoral nerve for this. Okay, so this is one of those not questions, which are very frustrating. But what's not a palpable landmark for your gluteal region? It is not going to be L2. So remember, L2 is just, it's going to be too high for this because right now we're really talking about like our sacrum, which is right in here. And then our like iliacus bones and our pubis bone, and things like that. So our ischial tuberosity, which is where our hamstrings attach, is a palpable landmark. Our PSIS is also a palpable landmark. And then our greater trochanter, where our external rotators attach, is also a palpable landmark for the gluteal region. So L2 would not be considered for this. Awesome. Great job. So remember our superior gluteal nerve does our gluteus medius and minimus. And then remember that the Trendelenburg test is used to identify gluteus medius weakness, which is innervated by superior gluteal nerve. And what happens in a positive test is that the pelvis will tilt towards the unaffected side. Remember our inferior gluteal nerve, that's going to do our gluteus maximus. Our sciatic nerve will do our posterior thigh muscles, and then our pudendal nerve, you're going to talk about that later on. So we're not even going to talk about it right now.
The other thing I want to add with the Trendelenburg test is even as a second year, we just had to do this in our OMM practical the other day, and I still got confused with it. Maybe that's just me, but like Olivia said, the hip is going to tilt down towards the opposite side. So to give you an example, let's say you ask a patient to stand on their right, like stand only on their right leg, so they lift their leg foot off the ground. If they have a right superior gluteal nerve injury or a right gluteus medius injury, the hip will tilt to the left. So they would stand on their right foot, lift the left foot up, and if it tilts down to the left, that's a right superior gluteal nerve injury or gluteus medius injury.
Okay, so for this one, it might have been a little tricky, but when we think about inferior gluteal nerve, so remember our big landmark is that piriformis muscle, which attaches from the anterior sacrum to our greater trochanter. And so our inferior gluteal nerve is going to exit the greater sciatic foramen below piriformis. The superior gluteal nerve is going to exit above piriformis. The lesser sciatic foramen, you would see that nerve diopter internus. Again, don't worry about the pudendal nerve. And then our adductor hiatus, that's our femoral artery and vein, which will eventually turn into our popliteal artery and vein. Okay, so in this one, we're a little split between external and interiliac vein, and like I think Tyler and I, by the end of like your anatomy journey here, we will be a broken record when it comes to blood supply, because if you know the blood supply, you know the venous supply, and if you know that, then you're also going to know the lymphatics. So it's just something to keep in mind, that even though it seems like a lot, if you know the blood supply, you know how the veins are going to go, and you know how the lymphatics are going to go. So remember, our superior and inferior gluteal, they're going to go into our internal iliac vein. And this makes sense because both the superior and inferior gluteal artery come off of the internal iliac artery. So it's that same ordeal there. Our popliteal vein will drain into our femoral vein, and then our femoral vein will drain into our external iliac vein. Because, like I said earlier, the femoral artery is a continuation of the external iliac artery. So it's really just working in the reverse between arterial supply versus venous supply.
And just to give you guys a little grace, they haven't covered the pelvis all that much yet, because we're only focusing on the lower limb and what we can see from once everything comes out of the pelvis. You're going to dive into all the branches of the internal and external iliac artery, and I promise you there's a lot of them, and it will make a lot more sense once you actually see it inside the pelvis. But this is just to give you a brief introduction so that you can trace things back. But just know when you guys go into, it's probably going to be covered during reproduction. You guys will be able to dive into all those arteries then.
Great job. So remember our popliteal fossa, that's that area right behind our knee. And so the borders are really going to be our hamstring muscles. So both semimembranosus and semitendinosus medially. Laterally, we're going to see the biceps femoris. And then inferiorly, we're going to have both heads of gastrocnemius. So remember, our gastroc has medial and lateral head. And so gracilis is not going to be a border of the popliteal fossa. Perfect. So yeah, our posterior compartment, and remember for both practical and your written, that at the medial malleolus, we're going to have Tom, Dick, and Very Nervous Harry, and that is one of the best landmarks that you can use. I think, remember another thing with your plantaris, look for that small muscle belly, and it's going to have a really long tendon, which can get confused as a nerve. Gastroc has those two heads. Soleus is underneath your gastrocnemius. So just landmarks and layers always.
And then just to give you a little bit more insight on that plantaris tendon, because it's called the student's nerve for a reason. Oftentimes students will think that that's the tibial nerve, but it's not. So the plantaris muscle belly is between the gastrocnemius and the soleus. So you'll see it's the long tendon for the plantaris running between the gastroc and the soleus muscle. So for lab, if you see that the gastroc is reflected, but you can still see the soleus and you see that long tendon, you can confidently say that it's the plantaris tendon. The tibial nerve, you have to reflect all three of those muscles that I just mentioned. So gastroc, plantaris, and the soleus all have to be reflected up, and then you'll see the tibial nerve running down towards that medial malleolus.
Yes, go ahead.
Is that I was just about to ask you that, Mr. Tyler. Is that also the same for the posterior tibial artery? Like they all have to be reflected to see it?
Yeah, so for tibial nerve, you had to have soleus reflected as well as to see the posterior tibial artery. So remember, in the pop fossa, we have the popliteal artery, and that's like the most deepest layer in there. And that splits into your anterior tibial artery and your posterior tibial artery. The posterior tibial artery and the tibial nerve are friends. So they're going to run together down the leg, and you're also going to be able to see them next to each other at the medial malleolus as well.
Okay, perfect. Thank you. I was trying to figure out the Tom, Dick, and Harry part on when you would see that that artery, but thank you.
And then one important point with that before I answer Jay's question from the chat, if they pin this on your practical exam, let's say they pin the tibial nerve, make sure you write tibial nerve. If they pin the artery and vein, make sure you put posterior tibial artery and vein. Don't put posterior tibial nerve. That's not a thing, and they'll mark you wrong. So make sure you have that distinction. But to answer Olivia looks like she just answered it. But to answer Jay's question, for those of you who didn't see it, he was asking about the superficial fibular nerve. So the common fibular nerve from the sciatic, it's going to run across that fibular head. And once it gets past the fibular head, it's going to divide into the superficial and deep. The superficial fibular nerve is going to pop out on the lateral aspect between the between the fibularis longus and the fibularis brevis. And then it goes down towards the foot. The deep fibular nerve is going to run with the anterior tibial artery underneath the tibialis anterior. Keep it moving. And also, for those of you that are just joining or joined a little bit ago, you can join the Kahoot. I think at the bottom there should be like a little link that you guys can join if you want to. It doesn't matter. I'm just letting you guys know, like, if you wanted to participate. But anyways, we'll keep going.
All right, good job. So just as we just said, popliteal artery terminates both as anterior tibial artery, which is going to go anterior. That's going to then become the dorsalis pedis, and our anterior tibial artery is going to run with our deep fibular nerve. And then our posterior tibial artery, that's going to stay posterior, and it's going to run just with the tibial nerve.
Just one thing that they like to test on the exams and test in lab is you have, and you guys might recall from the first one, although they didn't talk about it a whole lot, but when we were masters and first years, they love talking about anastomoses. They specifically like to talk about the popliteal region, the knee anastomosis, because when you guys are sitting in a chair, you flex your knee or extend your knee, depending on the positions of the muscles in the bone, you actually compress some of the arteries in the knee. And that's why you have this anastomosis around it. So just make sure you guys know that they're the genicular branches. They're very conveniently named. If it's superior, that means it's usually above the knee or just above the knee. And then if it's going lateral, it has lateral in the name. If it has medial, it's medial in the name, etc. Same thing for the inferior ones. In lab, so far, I have seen a superior lateral and a superior medial genicular artery. I haven't seen an inferior one, but I just want to let you guys know, keep that in mind for the lab as well as for written. I already said this, so I hope you guys get it right.
Okay, remember, anterior tibial artery runs with the deep fibular nerve. And then I don't think I've seen this on an anatomy exam, but you're going to come across it in other PowerPoints and textbooks. But if you see peroneal, it means fibular. And please know this, when I was shadowing this summer and we did like a surgery on like fibularis longus and brevis, they didn't call it that. They called it peroneus. So it is a very, very common term that's used in clinical practice still, especially in a sports medicine and orthopedics field. So it's great to know both names. Again, anterior tibial artery, deep fibular nerve, that is our anterior compartment. So we're talking about feet, or those that work with me in lab, you know, I like to go by teeth from medial to lateral, only because I know if you've ever played soccer, you know, you wear shin guards, or if you've ever been kicked in the shin, it hurts. And it hurts because we don't have a lot of muscles there. And so I go with teeth because I know that the T is the first muscle next to that tibia bone, and that's going to be tibialis anterior. We're then going to see like extensor digitorum longus, extensor hallucis longus. And just a note that with the hallucis, it's kind of tucked a little bit under the muscle belly of tibialis anterior and extensor digitorum longus. So just remember hallucis and follow the tendon. If you see multiple tendons, it's digitorum longus. If you see the one other tendon going to the big toe, that's going to be your extensor hallucis longus. And then the last one is going to be fibularis tertius. And then you'll be at your lateral compartment. Good job, guys. So foot drop. So let's think about this one a little bit. So when we got foot drop, we can really see it in really one location is the main one that you're going to hear about the most, but you could have it in another that's just kind of affecting this. So when you think of foot drop, you want to keep in mind two locations. One is going to be right at the common fibular nerve where it comes at the fibular head. So a lot of times it most typically does get compressed there. And so remember, with the common fibula, you're going to end up with foot drop. And basically what that means is that you can't keep your foot up, so it's going to keep hitting the ground. And so the way this question is asking it, it's talking about the deep fibular nerve, which is another way you can get foot drop. And this can also really happen with like ski boots is a very common thing. And so remember, our deep fibular nerve is that anterior compartment, and our tibialis anterior is one of our main dorsiflexors. So that means lifting your toes up. And so if you have injury to that, it means you can't dorsiflex. So what are you going to do? You're going to end up in plantar flexion. And so your foot's going to end up slapping the ground. And that's what foot drop is when you can't dorsiflex. So you're going to end up plantar flexing. So you're going to see that. Perfect job. Yep, it's going to be flexor digitorum longus. So hallucis, remember, that means our big toe. Tibialis posterior, no. And then popliteus, no. So, and another thing is our deep posterior compartment. So flexing the second toe, that's going to be our flexor digitorum longus. This is a really nice image, especially for lab to really look at it and get familiar with it. So just remember this like heel bone in the back, that's your calcaneus. And when you think about the different muscles you're going to see, some I definitely really want to highlight, especially as you're starting to look at the feet this week, or if you have it in lab, is that superficially, you're really always going to see your abductor hallucis. You're also going to have an abductor digiti minimi on this side. You're going to have your flexor hallucis brevis, but don't get that confused with your flexor digitorum longus tendon. Thank you. Sorry, I realized you can't see me moving my mouse. You also have lumbricals in the feet, and then you have a really important muscle, quadratus plantae, as well, and that inserts onto that flexor digitorum longus tendon. So some things just to keep in mind with the foot. And then remember, when you're looking at the plantar surface of the foot, that you're going to have medial and lateral plantar nerves and arteries. So that comes from your tibial nerve and posterior tibial artery.
Okay, so this is the tibialis anterior. It's one of the muscles in the anterior compartment. I actually think the next slide will help us out a little bit here. It's a little blurry, so I'm sorry about that. But the question was asking about which muscle can dorsiflex and invert. So dorsiflexion is the dorsum of the foot, so the top of the foot, and it's going to pull it up. So any of the anterior compartment muscles are going to help with dorsiflexion. But where it can get confusing is whether it's doing inversion or eversion. And my recommendation for you to figure out if it's an inverter or an everter is look at where the muscle is attaching and think about what would happen if it contracts. So if you were to contract the tibialis anterior, it's on this medial cuneiform bone over here, the part of the first metatarsal. If it contracts, it's going to pull up like this, and it's going to basically, I mean, it's going to invert the foot if it pulls up like that. So I know this is a kind of a blurry image here, a shoddy image, but think about where these muscles are attaching and think about, go back to physics, you know, if there's a pulley and a lever system, what's going to happen if this muscle contracts? Well, if it pulls up, it's going to either pull the foot up and it's going to slightly invert it. So that means that the toe is going, or the foot is going that way. That's it, awesome. So, yeah, the superficial fibular nerve is going to do the lateral leg muscles. If you recall, it's coming from, we can trace it back from the sciatic nerve. So the sciatic nerve is going to split into the tibial and the common fibular. The common fibular nerve goes past the fibular head, and then it's going to divide into the deep fibular and the superficial fibular nerve. The superficial fibular nerve is going to come out superficially, hence the name, between the fibularis longus and the fibularis brevis, and it's going to integrate those muscles along the way. Just to talk about the other nerves briefly, the tibial nerve, also coming from the sciatic, is going to be doing like the posterior compartment of the leg. The deep fibular nerve is going to travel to the anterior portion. It's going to run with the anterior tibial artery, basically right next to the tibial bone. And it's going to do the anterior compartment. And then the lateral plantar nerve is at the bottom of the foot, like Olivia was saying earlier, and it's going to do the muscles at the bottom of the foot.
Okay, so when we think about what does our gluteus maximus do, that is one of our biggest hip extensors, and we need this muscle to stand up from a seated position as well as going upstairs. So if someone has an injury to their gluteus maximus, so your inferior gluteal nerve, they're going to have some serious trouble getting up from a seated position or like from a squat, as well as going upstairs.
I got a little thrown off because this was added after the fact, so sorry about that. All right, I forgot I was muted. Okay, so this is a very common thing that you're going to see no matter what specialty you go into. You know, elderly folks, they lose their balance, they're going to trip and fall, slip and fall, etc. I was shadowing in EMS a couple weeks ago, and I literally saw like almost an identical case like this. So the biggest concern that you have with an elder patient that falls on their hip and, what they're prescribing, external rotation, shoulder compare, that's a clear, physical exam finding for someone that has a fractured femoral neck or dislocated hip. The biggest concern you're going to have, especially someone who's 85 years old, is that they're going to get avascular necrosis of the femoral head. Dr. Mormon loves to talk about this, but as we get older, just in general, excluding Dr. Mormon, the arteries are going to get, atherosclerosis. They're going to get thinner. There's more wear and tear. They're not doing as well as they normally would. But there's also some other arteries, let me go to the next slide, that are more prominent in younger folk. So, for example, this acetabular branch coming from the obturator artery, most of us that are in our 20s, 30s, et cetera, are going to have this artery here that's going to come in and help make the anastomosis there and are going to do fine. Older people, this artery tends to calcify. So they rely on the arteries coming from the femoral and the profunda brachii, profunda femoris, to supply the femoral neck. So the median circumflex femoral artery is going to be the main contributor to this anastomosis and supplying the femoral neck. So just know that if they're talking about someone who has a hip dislocation, they're likely going to be asking you a question about avascular necrosis. And they're going to want you to know like what arteries are involved. Okay, so we definitely have to talk about this one. So basically what this is describing is a ACL injury. So what they want you to know is special tests. So for first years that have taken PD, you guys know this was on your first exam for the knee. You need to know how to do anterior drawer. It's going to come up in OMM in the spring. As a second year, we had to do anterior drawer last week. This is a very common test. Even, if you go into primary care, sports medicine, et cetera, you're going to be doing this test often for people that play sports. So basically what they wanted you to know is how can you injure your ACL, and then how would you test to see if it's injured? So the common way that the ACL is injured is exactly how they described it, with a sudden change of position while the foot is like planted into the ground. So often you can think about football players who are trying to like juke someone out. Their foot is going to be planted and they're going to try to shift the weight at their knee and their hip. And that's going to cause too much strain on the ACL joint and it can cause it to tear. So the short explanation to this is that the way that an ACL can be injured is usually with a planted foot and then you have a sudden change in direction. It's common in all sports, as we all know. And then to do the anterior drawer test, it's exactly what it's describing. You're going to flex the knee up, and then you're going to grab essentially at the back of the leg at the gastrocnemius, for simplicity's sake, and you're going to pull the tibia towards you. If there's like laxity, meaning that the tibia gets pulled further than it should be pretty sturdy. If you guys were to do this on each other, it shouldn't move all that much. If there's a lot of laxity when you pull the tibia towards you, that's a positive anterior drawer test, and that means that the ACL is likely damaged. Just to go through the other ones, the valgus force. So like they said, that's going to be for the MCL. The way I think of applying a valgus force is I think about gum being attached at the knees so that the knees would be stuck together. So you're pushing the femur towards the midline, and they would stick to the knees would stick together like gum. So valgus gum, I don't know, that's how it works for me. But MCL is on the medial side. You would push the femur towards the midline and pull the tibia towards the lateral side. Same thing, if there's laxity, if there's pain, there's more give, etc., that's a positive test. Varus is just the opposite. So you would pull the femur towards the outside and then push the tibia towards the inside. That's going to be LCL, laxity, etc. And then the translating the tibia posteriorly, that's the opposite of the anterior drawer. That's for the PCL. PCL is commonly caused by, usually in basketball players, their knee is flexed and they land funny with a flexed knee, and that can cause a PCL injury. All right, we'll keep it moving. All right, yeah, so we're definitely going to talk about this. So this is the unhappy triad is like very high yield. I keep bringing up first and second year stuff, but like this comes up constantly. We were talking about this in second year last week. So the common way that the unhappy triad occurs is it's exactly how they described it. So usually there's some sort of trauma to the outside of the knee, which pushes the knee medially, which causes there to be too much force on the medial aspect of the knee. So think of lateral to medial force, too much force on the medial aspect. Those ligaments on the medial side are not going to be able to withstand that force, and they're going to rupture or tear. So usually it's a lateral to medial force. It can also occur with twisting movements, but anything that's going to cause too much strain on the medial aspect of the knee, that can cause the unhappy triad. So the way I remember unhappy triad is just MMA. So think about MMA fighters. They can get hit in the lateral aspect of the knee, causing that lateral to medial force, and that could cause an unhappy triad tear. So, and then the MMA is actually just like what the ligaments are. So the first M is MCL, the second M is medial meniscus, and then the A in the MMA is the ACL. So I think of MMA fighters, they can get an unhappy triad if they sustain that injury I was describing. So MMA, medial meniscus, MCL, ACL. And then if you guys recall from earlier, to test for this, those are all the tests that I was describing earlier. So not to keep going through this, but if you apply a valgus force to the knee, like I was saying before, you're pushing medially on the femur and you're pulling laterally on the tibia. That's going to cause stress on the medial aspect of the knee. Well, like we just said, MMA is focusing on those medial ligaments. You could have laxity or pain with that test. Anterior drawer, like we said, you're pulling on the tibia anteriorly. Laxity is a positive test. And then we didn't talk about this earlier, but McMurray's, you can test for the medial and lateral meniscus doing the McMurray's test. It's slightly different how you perform it. I'm not going to go into how to perform it because I think that it's just too much information for you guys right now, and I already feel bad for doing it before. But McMurray's is slightly different. It involves flexion, and then you carry it into extension, and then there's like external and internal rotation. Just know for now that the unhappy triad is caused from a lateral to medial force, causing increased tension on the medial aspect of the knee. And then the ligaments that are involved, you can remember by MMA. So medial meniscus, MCL, ACL.
Nice. Great job. So ankles are huge, and your biggest when you think about an ankle strain slash sprain, it's going to be your anterior talofibular ligament. It's the most commonly injured ligament, especially with an inversion injury or in like a supination position. So that is running on your like lateral malleolus and anterior because it's talofibular. So just think about what that means, your talus to your fibula. So that means it's going to be lateral and it's anterior. And so this is the most commonly injured in an ankle sprain. And then the other ligaments here are your medial, on your medial side, and we call it the deltoid ligament. So you don't usually see injury to your medial side or deltoid because it's so strong. And it makes sense. You have all these ligaments and it's very much protected. So typically you're gonna see the anterior talofibular ligament is the one that's going to be injured. Your deltoid is super strong, so that's not going to be. And then when it comes to lab and looking at the ligaments, especially review them on ZSpace. It definitely can be tagged. But when in doubt, if you know the foot anatomy and the bones, put two words together and add ligament to it, and chances are your answer will be correct. So just going through these, anterior tibio-talar ligament. It's going from the tibia to the talus. And it's anterior. Your tibio-navicular, so it's going from the tibia to your navicular bone, which is medial, and then your tibio-calcaneal, that's going from your tibia to your calcaneus. So when in doubt, put words together, and you will have your answer.
I'm just dumb and didn't go to the next slide. Here's the visual of exactly what Olivia was just telling you guys. I'm not sure why it's cut off. I'm sorry about that, but you can still answer the question.
Great job. So also just a friendly reminder to review these net anatomy images. This is very high yield for your lab practical, but also I just want to put this aside with your objective sheets. They are very deliberate. So when as you continue studying this weekend and reading back through your objective sheet, if something says recognize as part of the objective, it means it's going to be a picture. So know that. And that's going forward. Like Dr. Mormon is very direct, and the pictures come from Net Anatomy, they come from Moore's, or they come from our lecture or clicker slides, because all campuses need access to these photos. So just a like fact as you go through studying, if you didn't know that, if it says recognize, it's going to be a picture. So pay attention. Your arrow is pointing to your medial circumflex femoral artery. The one that's going laterally next to it, that will be your lateral femoral circumflex artery. You can see your descending branch of your lateral femoral cutaneous coming off of it. So remember that you usually have a descending, ascending, and transverse branch when it comes to those. And then on the right side, you can see a really nice profunda femoris as well. So just definitely review these, very high yield. Okay, good job. Again, very high yield. This is one of your objectives as well. So we know this is the knee, and we can see the femur on the tibia. So always starting with those landmarks, and then we're trying to decide is which side is lateral versus medial. And so the side here is going to be closer to the number 32 is going to be our lateral side, because you can really subtly see the head of the fibula. So just remember, landmarks are key. And you can think about that this is going to be your medial side then, because right on the other side, closer to the answer choices. So when we're looking at this, our ACL is going to be answer choice B. And we can discern this from two ways. So one, it is going to be anterior, and two, it's running from lateral to medial. C is going to be your PCL, and that's going to be running from medial to lateral, and that's behind. Make sure too that they typically, and when it comes to lab, they want you to write out the full name because people get confused between collateral and cruciate. So remember, your ACL and PCL is your anterior posterior cruciate ligament. So please know that it's very easy to get confused. A is going to be your lateral meniscus, and then D is not really going to anything, but if you were to go lower and closer to the tibia, that would be your medial meniscus. So definitely review these, know the orientation, be able to tell lateral from medial. I think that's one of the hardest things, but I saw this on a practical maybe 2 years ago, so it's all fair game. All right, good job. So, all right, back to orientation. As I always say, is we need to decide what's lateral and what's medial. And so we know our smaller bone is going to be our fibula, and our bigger bone is going to be our tibia. So we see up here above the green arrow is going to be our popliteal artery. And then it's going to split into an anterior and posterior. So the one that's running closer to our tibia is going to be our posterior tibial artery. And then the one that's running closer to our fibula is going to be our anterior tibial artery.
That's one.
Okay, this one was definitely super tricky. So let me go to the question. And first off, we know we're looking at closer to our ankle area. We can see that A is going to be our lateral malleolus. Remember, that's made up of our fibula. So always landmarks what's lateral, what's medial. Our bigger bone is our tibia. So that means D is going to be our medial malleolus. So we've narrowed that down. C is the turtle or the talus, because remember, the tibia sits on the talus or the turtle, as Dr. DeRusso says. And right when we cross this joint area between the tibia and talus is when we're going to have our dorsalis pedis artery. And then B is describing the tibia. And so now that we've been able to describe what all these are, we want to know the structure that bears the least weight in the ankle joint. And so, sorry, it's going to be the fibula. So keep in mind, like, your tibia is a very, very strong bone versus your fibula is a really small bone. It's like the radius and ulna situation, but in the leg. And so your lateral malleolus, like, while the fibula does play a role in stabilizing the joint, your weight bearing is all on your tibia and talus. So you have like your tibio-talar joint, and that's what does plantar flexion and dorsiflexion, and that's primarily really responsible for us being able to walk and bear weight. Versus our fibula doesn't really have that. So, and also you can think of it too with our fibula, like we have our like anterior talofibular ligament that we talked about. That's kind of attaching there, and think about how easy that like breaks. So it's gonna have like the least weight when it comes to the ankle joint because it's like for that reason as well, if you need another way of thinking about it. So, but I think it's very clear if you see the way that B sits on C, like your tibia sitting on the talus, that is the majority of the weight there.
Yeah, I mean, just think about the size of the bones, right? Like Olivia said initially, the fibula is super thin. It's very easy to get fractured. This isn't going to do a whole lot to help stabilize or to help weight bear. Even with this attachment, it only has a little bit of an articulation with the talus up here, but it's too small to do anything significant. So if you were to put a ton of force on this bone, it's going to fracture very easily. Whereas the tibia is strong. It's one of the biggest bones in the body, excluding the femur. It's got to be able to withstand high pressure. So that's That's why. We have like 1 or 2 minutes. Does anyone have any like last minute questions before we log off for the physio TA review?
I had a quick question.
If not, it's
Hello?
sorry, go ahead.
Oh, sorry. Yes, so I had a question about the popliteal fossa. So, I know that the popliteal artery is most, or I guess it's the deepest compartment of the fossa. So would that be considered most like posterior to the popliteal fossa?
I don't know if I would think about it as posterior in the popliteal fossa because it's technically the deepest structure, but that's more anterior if you think of it that way. So the popliteal vein runs on top of that popliteal artery. It's more superficial. But if we were to stand in anatomical position, that popliteal vein is technically more posterior. So I wouldn't do anterior, posterior. I would think of superficial and deep.
Or superficial and deep. Okay, sounds great. And
Right.
would that mean that the nerve would be most superficial?
Yeah. Yep.
Okay, sounds great.
It could also run like kind of next to them rather than being on top of the vein. Most of the time that I've seen it in the cadaver lab, the popliteal vein is superficial to the deep popliteal artery, and then any nerve that's running in that area is usually directly like adjacent to like on the side, either medial or lateral to it. Most likely medial. Um, but yeah, it could have some sort of variation, but for the artery and the vein, it's pretty consistent with what's deep and what's superficial.
Sounds great. Thank you so much.
All right, guys. Well, we had a small group today. Thank you all.